Um, this is Nabel Rajab Basha. I am an intern from Faisal University, and today I'll be presenting to you the dermatology review session. So first of all, just a quick recap so that we know that we're familiar with the terminology. I'll go over some terms. First of all, we have a macule patch, which are flat lesions, and they are distinguished by their size. So macule is usually smaller and patch is larger. The same applies to papule and plaques, which are raised lesions. They are not flat. We also have vesicles and bullae. Both are fluid filled. And we also have a pustule, which is filled with pus. The term acanthosis, it's very important to know. We'll mention it many times during the lecture. It is simply hyperplasia of the keratocytes. We have parakeratosis, which is keratocytes that retain their nuclei as they ascend through the epidermis. Hyperkeratosis is simply thickening of the epidermis, and spongiosis is edema within the epidermis, or simply fluid within the epidermis. Okay, so we start with the review session. So now we have a question. Does anyone want to read? Anyone would like to volunteer? Okay, so this question is simply asking about a patient who had antibiotics for UTI, and then he started having raised erythematous lesions, that come and go. So this presentation is a hallmark of a condition known as wheals or hives, or for more formal name is urticaria. Yes, exactly, urticaria. Guys, can you use the mic, or is it disabled? Okay, so, okay, anyways, so since the answer is urticaria, as you guessed, then the correct choice is the hyperpermeability of superficial dermal microvasculature. Because when you have the fluid flowing into the dermis, this will cause the lesions to rise and become higher. So this is urticaria, as we said, it's wheals or hives, erythematous raised lesions that fade within 24 hours. This is very important to know. It fades, it does not persist more than 24 hours in the same place. It's either immunoglobulin A mediated, triggered by the common pollens, or non-immunoglobulin A mediated. And this is seen in conditions like contrast, allergy, or vancomycin or opioids. And of course, as you know, immunoglobulin A mediated means type 1 hypersensitivity. And this is a picture showing urticaria. We can see fluid within the dermis. As we can see, dermis is full of fluid. Now, if this condition is extensive and it involves not only the dermis, but also the subcutaneous tissue, then this is known as angioedema, which is more dangerous, and sometimes it may cause suffocation and the patient may die. Angioedema, as you may know, it could be triggered by ACE inhibitors or other medications, or it could be hereditary because of deficiency in C1 esterase. I believe it is mentioned in your lecture. Okay, so moving on to the second question. So this is simply, as we can see from the picture, a salmon-like rash on the elbow. So let's go over the scenario. Previously healthy 30-year-old man comes to the physician because of a 2-week history of skin lesions on his elbows. He has no history of serious illnesses. Physical examination shows skin lesions on bilateral elbows. What is the most appropriate treatment? So what do you think the answer is? Yes, exactly. So this is a mild form of psoriasis. So the answer is the answer would be vitamin D analogs, for example, calcium or other medications, other topical medications, for example, topical steroids or cyclosporins. But if the disease is extensive, then we resort to other medications, for example, systemic immunotherapy or phototherapy. Now, as we said, it's salmon-like scaly red lesion on the external surfaces. An important association is nail changes and also seronegative arthritis. Seronegative arthritis, I believe you took it during this block. We have 4 types of seronegative arthritis grouped in the mnemonic pair. So P is for psoriasis, A is for ankylosing spondylitis, I is for IBD-associated arthritis, and R is for reactive arthritis. Now, there are 2 important clinical signs you have to know, very high yield to know. These are the Auspitz sign and the Kubler phenomenon. Auspitz sign is simply when you scrub off the lesion, there will be a pinpoint bleeding when you try to remove these salmon-like scaly red lesions. And Kubler phenomenon is simply plaques or formation of psoriasis that is triggered by trauma. This is with regards to the clinical presentation. As to histology, the hallmark sign is Monro microabscesses, and they are simply neutrophils in the epidermis. And you have to distinguish this from another condition that has neutrophils, which is dermatitis herpetiformis. Now, the difference is in psoriasis, the neutrophils are in the epidermis, whereas in dermatitis herpetiformis, the neutrophils are at the tips of the dermapapillae, and we'll come to it later, inshallah. As you can see, here are the neutrophils or the mono microabscesses at the most superficial layer of the epidermis. Okay, so anyone would like to read? Should I read it myself? We have a 6-year-old boy brought to the physician for evaluation of bilateral erythematous skin lesions on the flexures of the elbows and knees. He has been scratching the areas frequently, had similar lesions infinitely for the last 2 years. Yes, as Walid said, it is eczema. So eczema, it's an allergic condition. This is atopic dermatitis, to be more precise, because eczema has different subtypes, but the classic one is atopic dermatitis, exactly. So atopic dermatitis, it's associated with the allergic triad, the allergy triad. So what is the allergy triad? Any idea? 3 conditions. Yeah, exactly. So the answer is A, reversible decrease in FEV1 over FVC ratio, meaning that this patient is predisposed to asthma. So the allergic triad is asthma, food allergy, and atopic dermatitis. Exactly. So this is atopic dermatitis. Now it's simply papular vesicular oozing and crusting regions. The location, it's very important to know that it is on flexural creases. However, in infants, it may present, it frequently presents on the cheeks in infants. And as we said, it's type 1 hypersensitivity reaction. So that's why it's associated with the allergy triad, usually caused by a mutation in the filaggrin gene. If it persists, it becomes lichentified, meaning that it becomes thickened simply. And the main complications of atopic dermatitis, other than lichentification, are bacterial or herpetic superinfection. So the lesion itself, the eczema, may pave the way for bacteria or herpes virus to infect the skin and cause a superimposed infection. So this is simply showing the progress of atopic dermatitis, and I just want you to notice how initially, we can see here in C, we start to see spongiosis in the epidermis. It becomes filled with fluid, and then it becomes thickened. Just to make it easy for you, it is characterized by spongiosis, and then the epidermis becomes thickened. And we can see also here parakeratosis in the picture, so retention of a nuclei. And this is another type of eczema. 48-year-old man comes to the physician for evaluation of an intensely pruritic skin rash on his arms and legs for 12 hours. 2 days ago, he returned from an annual camping trip with his son. The patient takes no medications. A photograph of the skin lesions on his left hand is shown. Activation of which of the following cell types is most likely cause of the patient's skin findings? So what is the diagnosis in your opinion? Any ideas? So someone who went to the woods and came back with a rash. Yes, exactly. Poison ivy, or could be oak plant, but usually it's poison ivy. So this is allergic contact dermatitis. Allergic contact dermatitis, it's different from atopic dermatitis in that it is type 4 hypersensitivity mediated. So the answer here would be, if it's type 4 hypersensitivity mediated, the answer would be A, exactly. So this reaction is driven by T cells. This is just to summarize, as I said, poison ivy, oak, and nickel or belt buckle allergy. So another common scenario is a patient came with a rash on the belt region resembling a belt. This is simply nickel allergy. It's a subtype of allergic contact dermatitis. Okay, so this is another scenario. A 42-year-old man comes to the physician with 3 months history of an itchy rash on his face. 6 months ago, he was diagnosed with early onset Parkinson's disease. His only medication is pramipixole. Physical examination shows the findings in the photograph. There is copious dandruff. Yes, exactly. As you guys said, it is seborrheic dermatitis. So it's simply, we can see a lesion with erythematous base in areas that are rich in sebaceous glands. These are the forehead, the scalp, the nasolabial folds, the preauricular area. Yes, Parkinson is one of the causes. To be more general, CNS diseases are linked to this diagnosis, including Parkinson. CNS disease, including Parkinson, and also HIV. And it's simply, I like to think about it as an extensive dandruff. It's simply an extensive dandruff. And the species that is commonly associated with it is Malassezia furfur, and it is treated with topical antifungals and steroids. It's also common in neonates. Or infants. It comes on the scalp, and we call it cradle cap. And usually we just observe. We don't need to treat them. But if it persists, then we can resort to topical antifungals and steroids. Okay, moving on to another scenario. A 32-year-old woman with a recurrent vesicular genital rash comes to the physician because of 3-day history of a painful pruritic rash that began on the extremities and has spread to her trunk. Her only medication is acyclovir. Her temperature is 38. Examination of the skin shows several reddish purple papules and macules, some of which have a dusky center with a lighter ring around them. Yes, exactly. So the answer, as you guys mentioned, it is B, erythema multiforme. So erythema multiforme, it's a rash. As the name indicates, it can come in various shapes, but a hallmark shape or a specific shape is the targetoid lesion. A targetoid lesion, so it's like a target. And this rash could be drug-induced, or it could be associated with certain infections, for example, herpes simplex virus and mycoplasma pneumonia. So, for example, this year in our internal medicine clerkship, they got this scenario. A patient came with pneumonia and then he had erythema multiforme. So what is the causative organism? It is mycoplasma pneumonia. Or they could mention vesicles. In this case, it is herpes simplex virus. And it could be, of course, as one of you mentioned, drug-induced, especially with sulfonamides and antiepileptics. On pathology, you have to expect epidermal lymphocytic infiltration. And this is very important. So on the junction between the dermis and the epidermis, you would find lymphocytes. Erythema multiforme is on a spectrum of diseases. It's on the benign end of the spectrum. The severe end of the spectrum has Stevens-Johnson syndrome and toxic epidermal necrolysis. Okay, so moving on to this scenario, we have a 50-year-old woman comes to the physician because of blisters on her forearm that appeared 3 days ago. She also reports pain in her left cheek when eating and pain during sexual intercourse for the past week. She has not been sick for the past 6 months. She has started hiking in the woods on the weekends with her son a couple of months ago, but has been careful to avoid poison ivy. She has a history of hypertension and osteoarthritis. She recently started taking captopril and stopped meloxicam 2 weeks ago. She has a family history of pernicious anemia and Graves' disease. Vital signs are within normal limits. Examination shows multiple flaccid blisters over the volar surface of the forearm and ulcers on the buccal, gingival, and vulvar mucosa. The epidermis on the forearm separates when the skin is lightly stroked. So this is a positive Nikolsky sign. So we have blisters and positive Nikolsky sign and involvement of the mucosa. So what is the answer? Exactly, it's pemphigus vulgaris. I will elaborate more on this diagnosis, but let's check this related diagnosis. A 68-year-old woman comes to the physician because of a 2-day history of a rash across his trunk and extremities. For the past 3 months, he has had persistent pruritus in these areas. So the lesions are pruritic, different from pemphigus vulgaris. He started hiking in the woods with his grandson. His grandson, who often spends the weekends with him, recently had impetigo. He has hypertension, hyperlipidemia, and osteoarthritis of his thumbs. 5 months ago, he was treated for a gout attack of his left hallux. Current medications include captopril, hydrochlorothiazide, simvastatin, allopurinol, ibuprofen. There are diffuse vesicles, intense blisters involving the chest, flexures of the arms and shoulders. Rubbing on the skin does not produce blisters. So we have blisters involving the skin, a negative Nikolsky sign, and the mucosa is spared. The mucosa is spared. So this would be F, linear deposits for immunoglobulin G and C3 along the basement membrane on direct immunofluorescence studies. So antibodies directed against the most basal layer of the epidermis. It causes bullous pemphigoid. Now these two conditions are closely related. Just a second, please. Okay, so here is a table. The way I like to distinguish between the two is pemphigus vulgaris, as the name indicates, it's a vulgar diagnosis. So it's a rude diagnosis. It hurts you. That's why it's more extensive. It involves the mucosa, and the blisters are easily ruptured, predisposing to superimposed infections and also fluid loss, because when you lose the skin, there's fluid loss. Whereas in bullous pemphigoid, the B in bullous stands for benign. It is the benign form. So the mucosa is usually spared, and there's a negative Nikolsky sign. This is why it's benign. If the bullae do not rupture, there would be no superimposed infections and no fluid loss, and it's not fatal. And of course, you have to distinguish based on the antibodies. So antibodies against desmosomes is seen pemphigus vulgaris. Antibodies against hemidesmosomes seen bullous pemphigoid. Sorry, someone told me to go back. Miran? Yes? Yes, Miran? Why is it not H? Subepidermal separation with full thickness epidermal necrosis on skin biopsy. I believe this is pemphigus vulgaris. I'm not completely sure, to be honest. I did not check this option, but the answer is definitely F. I believe that H is pemphigus vulgaris because of the epidermal necrosis within the skin biopsy. So I think this is what they are referring to. This is the necrosis, this extensive necrosis of the epidermis. This is seen in pemphigus vulgaris. Epidermal is bullous. Yes, to be honest, it is a bit confusing, but I did not check this option, to be honest. I'm not sure why, but I think it leads to another thing. But I think F is the more accurate answer. It's clear. It's linear deposition of immunoglobulin G and C3 along the basement membrane. So you have antibodies directed against the hemidesmosomes, to be exact. Hemidesmosomes. Sorry, I did not answer your question, but I believe the full thickness epidermal necrosis, I think they're referring to this one. On this section, this is present pemphigus vulgaris. And this is because of the fishnet-like pattern. Again, this is the linear immunofluorescence specific for bullous pemphigoid. So the answer is F, as we said. Okay. And you can see that here the cells are intact. In the upper right picture, the cells are intact. This is why the blister does not rupture. It's more intact than pemphigus vulgaris. You can see the extensive necrosis here. The correct answer is F. The correct answer is F, linear deposits in the globin G and C3. C is pemphigus vulgaris. It's definitely pemphigus vulgaris. Okay, so a 24-year-old man comes to the physician for the evaluation of a severely pruritic skin rash. Physical examination shows a symmetrical rash over the knees and elbows with tense groove vesicles and several excoriation marks, microabscess in the papillary dermis. So as I mentioned, this is just like psoriasis, but the neutrophils are in the dermis. So this condition would be, so we have a rash on the extensor surfaces. Yes, dermatitis herpetiformis, which is associated with celiac disease. So the answer would be C, gliadin-dependent hypersensitivity. Gliadin is a protein found in gluten. The answer is C. As I said, it's vesicles and urticaria on the extensor surfaces, more common in males than females, associated with celiac disease, and the microabscesses are at the tips of the dermal papillae. Contrast with psoriasis, which has microabscess in the epidermis. Okay. So this disease is related to rheumatology. I think you had it in your blog. And otherwise, the 28-year-old woman comes to the physician because of 14-day history of painful red nodules on her legs associated with malaise and mild joint pains. She reports that the nodules were initially smaller and distinct, but some have fused together over the past 3 to 4 days and now appear like bruises. There is no preceding history of fever, trauma, or insect bites. Her vital signs are within normal limits. A photograph of the tender lesion on her shins is shown. The remainder of the examination shows no abnormalities with negative ASO. ASR is 30. What is the most appropriate next step in management? Okay, so guys, we have a young female presenting with red bumpy nodules on the shin. So exactly, this is erythema nodosum, and the diagnosis here, it's likely sarcoidosis. Sarcoidosis. So what is the answer? If it's sarcoidosis, what do I expect? The main organ involved in sarcoidosis. Yes, exactly, the lungs. So we have to do X-ray of the chest, because X-ray would show us the involvement. Could be the hilar lymph nodes or hilar lymph nodes and the lungs, or only the lungs. So this is sarcoidosis. Erythema nodosum is a common finding in sarcoidosis. Actually, erythema nodosum is a subtype of panniculitis. Panniculitis is simply inflammation of the subcutaneous adipose tissue, and erythema nodosum presents as tender bumpy nodules. It has many associations, mainly sarcoidosis, also associated with IBD, TB, histoplasmosis, and group A streptococcus. Okay. Okay, so we have a 48-year-old woman comes to the office because of 4-week history of an itchy rash at both of the wrists. Upon questioning, he mentions that he has also had difficulty swallowing and 2-kilogram weight loss during his time. He says he had the same rash 6 months ago and that it resolved without treatment. He has no history of CSL service remarkable for psoriasis in his grandfather. He does not smoke cigarettes or alcohol. Photograph of the lesions is shown. The remainder of the examination shows no abnormality. Which of the following is the most likely diagnosis? So yes, as one of you mentioned, this appears to be lichen planus. Lichen planus, as you know, it's characterized by the 6 P's. So pruritic purple polygonal papules and plaques, planar also. And lichen planus, it could be on the skin, and usually it is associated with hepatitis C. Whenever you see a patient with lichen planus, you have to order hepatitis panel. Sometimes, however, you may find lichen planus on the oral mucosa, And in this case, you would have white lacy lines. This is known as Wickham striae. And lichen planus on histology, it has interface dermatitis. So lymphocytic infiltration at the junction between the epidermis and the dermis. Just like psoriasis, lichen planus could be triggered by trauma. In other words, lichen planus has a Kubna phenomenon. Okay, and again, lichen planus could be associated with hepatitis C, so we have to check hepatitis C. It may be associated with HIV and S inhibitors, but the main association is hepatitis C. Okay, so 68-year-old man comes to the physician because of 3 months history of a painless skin lesion on his neck. The lesion has gradually become darker in color and is sometimes itchy. He also noticed one similar lesion on his lower back. He's a retired gardener. He has smoked half a pack of cigarettes daily for 40 years. Vitals within normal limits. Physical examination shows a 0.8 centimeter hyperpigmented papule on his neck and a 0.6 hyperpigmented papule on his lower back, both of which have a greasy and wax-like appearance. A photograph of the neck is shown. Which of the following is the most likely diagnosis? Exactly. So the answer is F, seborrheic keratosis. So this is a typical lesion. Actually, they described the lesion in the question. It says greasy, wax-like. I would also add stuck-on appearances. Seborrheic keratosis is usually a benign finding, but if you find multiple seborrheic keratosis, this is known as a lizard trilat sign, and it may herald an underlying malignancy, specifically adenocarcinoma. And the biopsy would show keratin-filled cysts. Okay, so lizard trilat sign, you have to be aware of this. This also could herald the underlying malignancy. A 23-year-old woman comes to the physician for annual health maintenance examination. She feels well. She's 155 centimeters, weighs 79 kilograms, BMI is 33. Examination shows a skin rash over both axillae. A photograph of her left axilla is shown. So this is, as Walid answered, this is a gastric malignant lymphoma. Sorry, not gastric malignant lymphoma, sorry. It's D. Well, this is acanthosis nigricans, and in patients with insulin deficiency, also seen in malignancies. But we're talking about, when we talk about a malignancy, we talk about adenocarcinoma, not lymphoma. So B is not correct. If it was adenocarcinoma, then we can't consider this option, but here it is lymphoma. So it's not the correct answer. The correct answer is the polycystic ovarian syndrome. Why? Because PCOS is associated with insulin resistance, and insulin resistance related cases like diabetes, PCOS, and also obesity are all associated with acanthosis nigricans. Okay. Thickened velvety hyperpigmented plaques. 58-year-old white man with hypertension and type 2 diabetes comes to the physician because of 3 months history of a painless lesion on his lower lip. He has smoked 1 pack of cigarettes for 20 years. He has worked as a fruit picker for the past 25 years. His current medications include captopril and metformin. Examination of the oral cavity shows single ulcer near the vermilion border. Yes, exactly. It's squamous cell carcinoma. And this patient has multiple factors. He's immunosuppressed, and he has been exposed to the sun for a long time. And also the location, the lower lip is specific for squamous cells, so squamous cell carcinoma, whereas the upper lip is specific for basal cell carcinoma. So other risk factors, as I said, immunosuppression, chronic wounds, burn scars, interstitial carcinogens. And if a chronic wound doesn't heal and it becomes uglier in shape, we have to consider the possibility of a marginal ulcer, meaning that the chronic wound is now has underwent metaplasia and dysplasia, and then became squamous cell carcinoma. And a common precursor lesion of squamous cell carcinoma is actinic keratosis. On histology, the squamous cell carcinoma is identified by keratin pearls and intracellular bridges, and of course, a lot of dysplasia. But two distinguishing features are keratin pearls and intracellular bridges. And actinic keratosis, I believe you are familiar with this term. It usually appears on sun-exposed areas. It's scaly. Yes, exactly, solar keratosis. This is a picture of actinic keratosis. As you can see, it's scaly on sun-exposed area. This is another malignancy. A 62-year-old man comes to the physician because of skin lesion on the nose. The lesion has greatly increased in size since it first appeared 11 months ago. He's a farmer and lives together with his wife. His mother died of metastatic melanoma. He smoked 1 pack of cigarettes daily for 30 years and drank 1 to 2 glasses of whiskey on weekends. An examination of the skin shows an untender lesion at the right medial canthus. So exactly this is basal cell carcinoma. You can see the classic pearly appearance with central depression, and we may appreciate telangiectasia here. So the answer is basal cell carcinoma. Yes, with telangiectasia, exactly. And usually, so what one of you is asking, when will it be C? Keratoacanthoma, it's usually in the middle, you don't find a depression. It's usually like you find a keratin and there is buildup of keratin in the middle. It has an ugly appearance. Did I answer your question? It's usually not a depression, I believe. Okay. So basal cell carcinoma, now we said it's more common on the upper lip, right? It's so lower lip is specific for squamous cell carcinoma. Upper lip is, yes, exactly, spontaneous regression for C. Keratoacanthoma undergoes spontaneous regression. Thank you, Hadil. The upper lip, if it has a lesion, we should consider basal cell carcinoma. And it's usually above an imaginary line connecting the earlobe to the corner of the mouth. Perinodule with telangiectasia, as we said. Of course, I saw other forms of BCC in your lectures. So you have to consider other subtypes other than the pearly nodule, but I included the most common one here. And histology shows basaloid cells with palisading pattern, meaning that they are in line with the same axis. You can see the cells here, they are in line all together with the same axis. You can see a lot of nests with basaloid cells, and they are in the same axis when arranged next to each other. Yes, exactly, soldier-like. Moving on to the most aggressive malignancy, a 63-year-old man comes to the physician for the evaluation of a skin lesion on his chest. He first noticed the lesion 2 months ago and thinks that it has increased in size since then. The lesion is not painful or critic. He has type 2 diabetes, hypercholesterolemia, glaucoma. The patient has smoked 1 pack of cigarettes for the last 40 years and drinks 2 to 3 beers on the weekend. The lesion is partly elevated on palpation, does not change its form on pinching. So it does not change its form on pinching. So it's definitely not dermatofibroma. A photograph of the lesion is shown. Which of the following is the most likely diagnosis? So the answer, as you guys said, it is A, malignant melanoma. Why? Because of one of you mentioned the ABCDEs. So asymmetry, irregular border, color variegation, evolution. No, I put images in the exam and you can diagnose it from. No, they would definitely give you details. For example, here they're telling you the lesion. You first noted the lesion 2 months ago. It has increased in size since then. So there is evolution. There is, as we can see, a regular border. So it's a typical presentation for melanoma. And as we said, differentiated from benign nevi by the ABCDE, it has high metastatic potential. That's why sometimes we do the sentinel lymph node biopsy test to look for any metastasis to the local lymph nodes. And apart from ABCDE, if they bring you say a black lesion and they have sensory symptoms, for example, it's prophytic, or if there is tingling, or if there is pain, these are all signs of melanoma. Sensory symptoms are signs of melanoma. You have to keep this in mind. S100 marker on immunohistochemical staining. It's an important marker on histopathology, the S100. First lobe thickness is an important prognostic indicator. It's as you can see, it's the length from the granular layer to the deepest intradermal tumor cells. So it can be used to indicate the prognosis. And BRAF is the main causative mutation. Now, it's not that important to know, but I listed BRAF here because based on BRAF, we have chemotherapy for melanoma. So we sometimes use certain agents. I believe it's called verofenib. It's targeted against BRAF, but I don't believe you have to know this. Early detection and surgical excision are curative. Otherwise, palliative chemo radio are implemented. I don't know about the HMB45, to be honest. I think S100 is the main marker. Also, guys, there's one information you need to know: melanoma or melanocytes. Where do they come from? You know the embryologic origin of melanocytes. I think it's high yield. You should know this. Yes, exactly. It comes from neural crest. So neural crest cells give rise to melanoma, melanocytes. Neural crest, exactly. These are the multiple forms of melanoma. Of course, the acral lentiginous form is commonly seen in Black people. The acral lentiginous form, there are multiple types. And of course, if you see a nodular one, this means that there is a vertical growth, and the melanocytes are growing into the dermis. That's why it became nodular in appearance. So this is very poor prognosis. Yes, as Walid said, it has very poor prognosis if it's vertical. This one, it appears, the one on the left, it appears to be still in the radial phase. It's not growing vertically, so probably it has not metastasized. A 43-year-old man comes to the physician because of redness and swelling of his right leg over the past 2 days. He reports that it is very painful to touch. He has had fever and chills. He has no chest pain or shortness of breath. He has a history of type 2 diabetes and underwent a saphenous vein stripping and ligation in his right leg 3 years ago. He works as a security guard. He does not smoke or drink alcohol. His medications include metformin and acetagliptin. Temperature is 38.7. Pulse is 99. BP is 138/72. Examination shows an 80 centimeter indurated tender warm erythematous skin lesion with sharply demarcated margins on his lower leg. There is no inguinal lymphadenopathy. TOWIB in Tertigo is noted. Which of the following is the most appropriate next step in management? So what do you think the answer is? So we have tender warm erythematous skin lesion with sharply demarcated margins. Sharply demarcated margins. So we should consider, yes, exactly, it's erysipelas. So the answer would be, well, of course, so this goes back to microbiology. What are the organisms that cause erysipelas or cellulitis? It's usually group A Streptococcus. Group A Streptococcus is the main organism, followed by Staph aureus. However, in purulent cellulitis, it's Staph aureus is the commonest, but usually it's group A Streptococcus. So we target this organism with both A and B. Both options are correct, but here there is a clinical aspect. The patient is feverish, he has high fever, his pulse is high. This is a bad presentation. You cannot just give him oral antibiotics and send him back home. So the answer would be the intravenous cefazolin therapy, but they have the same coverage. So I would say, especially for third year level, both A and B are correct. And also this patient is immunosuppressed. So the patient is immunosuppressed and he's feverish. So the infection is not simple. We cannot discharge him on oral therapy. We have to admit him and give him intravenous cefazolin therapy. Okay, and this is another question. One day after undergoing open colectomy, 65-year-old man with colon cancer experiences shivers. The procedure was originally scheduled to be done laparoscopically. but it was converted because of persistent bleeding. The surgery was uneventful. So simply post-op wound, and the wound became erythematous. And when you palpate the wound, you can feel that there are crackles, or you can feel that it's emphysematous, there is air. And WBCs are up to the roof, 18,000. So yes, as one of you mentioned, the answer is C, surgical exfoliation with debridement. This is necrotizing fasciitis, and actually it's a fatal disease. It's commonly fatal. So we have to intervene early. We intervene surgically and also with aggressive course of antibiotics. We usually give vancomycin, clindamycin, and tazocine. So triple antibiotics. This disease is very aggressive. And of course, necrotizing fasciitis, why did I mention this point? Why 3 antibiotics? Because it's usually polymicrobial. Of course, you heard about the flesh-eating bacteria, subtype of group A Streptococcus, but usually the disease is polymicrobial. So multiple organisms are causing this presentation, are causing this infection. It's not only one organism. Another disease on infectious. So a previously healthy 5-year-old boy is brought to the physician because of a 2-day history of a rash and swelling on his left lower leg. His mother says the boy complained of an insect bite while playing outdoors 3 days before the onset of the lesion. His immunizations are up to date. He's at the 50th percentile for height, 85th percentile for weight. He has no known allergies. His temperature is 38.5, pulse is 120, blood pressure is 95/60. The left lower leg is swollen and tender with sharply demarcated erythema. There is a narrow red line with a raised border that extends from the lower leg to the groin. The remainder of the examination shows no abnormalities. Which of the following is the most likely diagnosis? So this it looks like erysipelas. So you can see a raised border. It's erythematous, sharply demarcated. So this is erysipelas. So as Walid said, the answer would be Streptococcus pyogenes infectious, group A Streptococcus. Again, guys, erysipelas and cellulitis, the most common etiology is group A Streptococcus. However, if the cellulitis is purulent, there is a subtype of cellulitis known as purulent cellulitis. Then the commonest organism would be Staph aureus. Yes, Miral, purulent cellulitis. But the normal type of cellulitis, it's usually group A Streptococcus, but purulent cellulitis is Staph aureus. I think for the sake of the exam, just remember group A Streptococcus. Okay. Where did I go? Sorry. Okay. A 36-year-old man comes to the physician because of a 2-day history. Going back to the point Miral mentioned, Staph aureus is also more common in folliculitis and its successors, which are furuncles and carbuncles. Why? Because there is a purulence. So always the word purulence is associated with Staph aureus. So these 3, along with purulent cellulitis, they are associated with Staph aureus more than group A Streptococcus. Like, 36-year-old man comes to the physician because of a 2-day history of malaise and a painful pruritic rash on his lower back and thighs. His temperature is 37.8. Physical examination shows the findings in the photograph. Skin scrapings from the thigh grow neutral colonies on McConkey agar. The colony producing bacteria are oxidase positive. You know, I would make the scenario a bit easier, and I would add that the patient. Yes, exactly. Yeah, so it's a swimming in pool. Yeah. So we did the McConkey agar. McConkey agar is selective for gram-negative bacteria. So we have a gram-negative colony. However, it's not lactase positive. It's oxidase positive. The colony producing bacteria oxidase positive. So oxidase positive gram-negative organisms. This is probably Pseudomonas aeruginosa, and it follows it's seen in hot tub folliculitis. So we can see multiple follicles are involved. Many of them are erythematous. So this raises suspicion for hot tub folliculitis, which is caused by Pseudomonas aeruginosa. Pseudomonas aeruginosa is present in another dermatologic condition, Eczema gangrenosum. It's also a common etiology of Eczema gangrenosum. Did you take it? Eczema gangrenosum, I remember we had it in our third year, but we had a different microbiology doctor. So I'm not sure if you had it. Okay, sorry. Then it appears that you did not have this disease. So just remember Hattab folliculitis. So this is a 9-year-old boy brought to the physician by his mother because of an itchy rash on the right side of his scalp and progressive loss of hair for 1 month. He has no history of serious illness. His younger sibling was treated for Particulosis capitis 3 months ago. The boy attends elementary school but has not been going for the last week because he has been too embarrassed by the rash. He appears anxious. A photograph of the scalp is shown. Occipital lymphadenopathy is present. The remainder of the examination shows no abnormalities. So the answer would be yes, it's actually no, it's not E. It's not tinea capita. It's not sorry. It's not pediculosis. Yes, it's D, oral griseofulvin. So this is in pediculosis usually there is no lymphadenopathy. Okay, no lymphadenopathy, and this why I include this question because I want to raise a certain point that in tinea capitis and also tinea that involves the nails, it's difficult to treat with topical treatment. So we have to give these patients oral treatment. So for tinea or for dermatophytes involving the head and the nails, we have to give oral treatment. And usually we give oral griseofulvin. However, if it was tinea corporis, for example, tinea cruris, tinea pedis, we can give topical agents. And always the name indicates the location. So pedis is for feet, cruris is for the creases, usually in the inguinal crease, and corporis is for the body. So the answer here is the oral griseofulvin. Okay, a 16-year-old girl is brought to the physician for evaluation of severe acne on her face, chest, and back for the past 2 years. She has no itching or scaling. She has been treated in the past with a combination of oral cephalexin and topical benzoyl peroxide without clinical improvements. She's sexually active with one male partner and they use condoms inconsistently. So this is simply a patient with severe acne. She failed the first-line management, and now we're resorting to the most aggressive treatment of acne. What precautions should we take? What is the answer here? Yes, A is correct, but there is something we have to do beforehand. A is correct, but there is something at this stage. There is something. Yes, exactly. So we have to know for starting her on oral contraceptives. We have to know if she's pregnant or not, because vitamin A is harmful to the baby. So we have to see if the patient is pregnant or not with serum beta HCG. And if she's not pregnant, then we can start her on 2 forms of oral contraceptives. And usually we give an IUD and oral contraceptive. So IUD and oral contraceptive, 2 methods of contraception. Okay. And also we need to draw lipid levels to establish a baseline. We also need to draw liver enzymes also to establish a baseline, because these are all adverse effects of this treatment. طيب. 17-year-old girl comes to the physician because of 3-year history of acne on her face and chest. She has no itching or scaling. She's concerned about the possibility of facial scarring and has never sought treatment. She has no history of serious illness. She takes no medications. She's 160 centimeters tall and weighs 58 kilograms. Her vital signs are within normal limits. Examination shows several open comedones in the face and chest. So okay, this one she never received treatment. So we want to start with something easy and simple, no side effects. So the answer will be topical benzoyl peroxide, which is a keratolytic agent. Now, usually we start with topical benzoyl peroxide or a topical form of vitamin A, topical retinoid. Okay, then we can add topical antibiotics. If these don't work, we can use oral antibiotics, and the last resort is oral azithromycin. But since this patient did not receive any medications, then she's eligible for a keratolytic agent, topical benzoyl peroxide. Okay, I think we're almost done. A 16-year-old boy is brought to the physician by his mother for the evaluation of hair loss. He first noticed patchy areas of hair loss on his scalp 3 months ago. The bad areas have gradually increased in size since then, and new ones have developed. The patient does not have itching or scalp pain, but reports an occasional burning sensation in the affected areas. He is sexually active with 2 female partners and uses condoms inconsistently. He was diagnosed with a panic disorder after his uncle died in a motor vehicle collision 1 year ago. Since then, he has been receiving cognitive behavioral therapy. Vital signs are within normal limits. A photograph of the scalp is shown. 6 millimeter hair bundle is grabbed and pulled firmly. 9 strands of hair fall out. Dermoscopy shows short vellus hair, tapering hairs, and black spots. Okay, guys, so let's analyze this question. So this is alopecia. Alopecia is usually classified into cicatricial and non-cicatricial, meaning inflammatory and non-inflammatory. Cicatricial means like scars and so on. So this is non-cicatricial. So it's not infectious etiology. It's not, for example, pediculosis or tinea capitis. This is non-cicatricial. So we have different subtypes of non-cicatricial alopecia. This could be androgenetic alopecia or telogen effluvium or alopecia areata. Now, they gave us 2 signs here, important signs. The hair pull test is positive, and the dermoscopy shows the exclamation sign. Sorry for the technical issue. So I'll continue explaining. Okay, so we have an exclamation sign and also a positive hair pull test. So this would be, it would be alopecia areata. The exclamation mark is specific for alopecia areata. And a positive hair pull test may be seen in telogen effluvium. However, in this scenario, it goes more with alopecia areata. If they want to make the question easier for you, they would add a person with a history of type 1 diabetes or Hashimoto thyroiditis, because these are autoimmune conditions, and alopecia areata is autoimmune in nature. Okay, and another thing is we saw in the picture that the lesions are not like diffuse; it's irregular patches. So androgenetic alopecia would not present like this. Neither does the telogen effluvium. So the answer. Okay. Yeah, I know. I'm turning the screen on. Sorry. So it's not minoxidil. Minoxidil is for androgenetic alopecia. Oh, okay. Sorry. So the answer is intralesional corticosteroid. Why? Because of alopecia areata. This is alopecia areata. We cannot say topical minoxidil because minoxidil is used for androgenetic alopecia, which is male pattern baldness. If it was male pattern baldness, we would see diffuse hair involvement and more pronounced on the temporal regions. So it will be bitemporal. But as I said, this one is very irregular and ugly in shape. Okay. Wait a second. I will share screen from my mobile phone. Sorry, I took much from your time, but we're almost done. Open office. Okay, I'm sharing the screen. Share. Okay. Can you allow me to share the screen, please? My user is COM. Yeah, thank you. Okay. طيب. Share screen. Start broadcast. Okay. طيب, so we'll move to the last question, which is on pharmacology. Okay, so we have a 62-year-old woman evaluated because of 3-day history of headache, nausea, and decreased urination. Laboratory studies show the following. Sodium 136, potassium 3.2, chloride 115, magnesium 1.4, and urine pH is 7. So arterial blood gas analysis in room air shows a pH of 7.28 and bicarbonate concentration of 14 milliequivalents per liter. Prolonged treatment with which of the following drugs would best explain this patient's findings? Any idea? Yeah, sorry, yes, Miral. The answer was intralesional triamcinolone therapy, which is an intralesional corticosteroid, because this is an autoimmune condition. Okay, this is the answer. Oral finasteride and topical minoxidil are used in androgenetic alopecia. Okay. طيب, okay. So here we have a patient with potassium on the lower margin. Magnesium, I believe it's also low. We have an alkalotic urine, and the patient has a very low pH, a pH of 7.28, and the bicarbonate is 14. This is a subtype of metabolic acidosis. Yes, exactly. The answer is amphotericin B. Amphotericin B causes type 1 distal RTA. I don't know. Did you guys take RTAs? Or maybe in your second semester, I'm not sure. But amphotericin B causes a condition known as type 1 distal RTA. So there will be metabolic acidosis, and at the same time, the urine is alkalotic. You know, I remember it this way. The D in distal stands for deceitful. So it tries to tricks you. It causes an acidotic blood, but the urine is alkalotic. And anyways, amphotericin B, you have to know that it's used in the management of leishmaniasis. It forms pores on the wall of the organism, on the cell wall, cell membrane, and we commonly prescribe liposomal amphotericin B. Why? Because liposomal carries less risk for nephrotoxicity. Sorry, did stop sharing? Yes. Pores in ergosterol. Pores in ergosterol. Yes. Yeah. As you said, I think it's pores in ergosterol. So it's part of the cell membrane, isn't it? Right. So it's part of this. Yeah. So it's yeah. It's pores in the pores in the ergosterol. So it affects the cell membrane, and we usually give the liposomal subtype to avoid nephrotoxicity. And one of the also side effects is hypokalemia. You should be aware of this. It's used for leishmaniasis. I think you took this lecture with Dr. Manal. Leishmaniasis, uh, as you may know, it's treated with the sodium stibogluconate, usually in mild cases. For example, only cutaneous leishmaniasis, it's treated by the sodium stibogluconate. But if it's diffuse, if it's visceral leishmaniasis, or also known as Kala Azar, then we have to give a more aggressive treatment. And for these cases, we usually add amphotericin B on top of sodium stibogluconate. And it's transmitted by the sandfly. Okay, so this is about amphotericin and leishmaniasis. So I think we're done. Do you guys have any questions? Any question